Hello guys, welcome back again. So from previous videos, we talked about the history taking, examination, as well as the 7-minute questioning phase of investigations, management, and presenting your findings. So today we'll focus on the A to E assessments, and it will be 18 minutes in Newcastle University. And we'll talk through the brief histories at the start, the A to E assessments itself, as well as the S bar at the end. We'll touch on potential scenarios I think might come out in your exam and the mindsets behind it. Today we'll go through my failed feedback to see what kind of things that the examiner wasn't happy about, as well as a good one, the one that I passed. First of all, the A to E assessments. So when you go into the room, obviously you need to take a brief history to find out what happened actually, right? So you go in, hi, my name is Chris, I'm one of the doctors. And nurse will probably brief you a little bit. So like, hello, my name is Rebecca. I'm one of the nurse. So this is 55-year-old male who's called John, whose new score has dropped from 0 to 6. Please come and review him. And yeah, no worries, I'll come and see him. Then you talk to John himself. So, hello, what kind of problems do you have? Oh, sorry. So hello, like how can I help today? You might be saying like, shortness of breath, coughing up sputum, things like that. And for this part, for the brief histories, you don't need to go through family history. It's not important at all. Past medical history, you might need to ask, and medication history, you also need to ask as well. But you don't need to go through everything. Just quickly go through the Socrates. So for example, they might tell you, I got chest pain. Socrates it, and then if it is a respiratory system, then you ask respiratory cardinal symptoms quickly, and you don't really need to go through eyes. Just briefly ask that. Is there any thoughts about what this might be? Is it the first time? Past medical history, medication history, allergies, and smoking, alcohol, relevant social history. And then if you think that there might be some travels, just double check on that. But some conditions to be aware of is Parkinson's disease. So for Parkinson's disease, there are two things to check. First of all is that the patient might have swallow difficulties. So if they got pneumonia, there's a higher risk of them getting an aspiration pneumonia, which means that when you look at the chest x-ray, it won't be a consolidation at the base area, the lower zone of the lung, which is more common in normal like CAP or HAP, right? Community acquired pneumonia. For aspiration pneumonia, it will usually be in middle zone. It could be in middle zone or upper zone. So that's why it's a bit different. And for the antibiotics, you need to ask for guidelines. And also for Parkinson's disease, they need to take medications promptly. So whatever the time they are given the medication, they have to take it at that time. So in A&E, there's the ricticketing patch, which is a dopamine agonist. So you can prescribe that for them. After you have a brief understanding about what the patient is going on, like John has fever, chest pain, coughing out sputum, a COPD, significant smoking histories, you're going to start quickly screen around the room to see for any hints. And when it comes to anaphylaxis, be aware that the patient might have, for example, like an IV access and connected to a random medication, for example, called Mosler. And be aware of that because you might need to remove that, or else your adrenaline is not going to work. And that happened to me when practicing. I keep giving like adrenaline, but it doesn't work because the patient is connected to a comoxiclav. Oxygen-wise, you check if the patient has COPD and the patient is on a normal oxygen mask with 15 liters and the stats is 98%, then you have to change it. They might prepare some inhalers, vomit bowls, or stool samples around the table. Double check on that, or ask the nurse for like, oh, what's that? Is that this patient's vomit sample? And look inside for any bloods, okay? So going on to the actual A to E assessments, which is the tasty part. So first of all, the A, airway. If the patient is able to talk back to you, then airway is patent. nothing needs to be done. You can go on to B. Some options that you can do is jaw thrust, head tilt, chin lift, right? But you can also pull the bed out or push the bed out so that you can do those maneuvers more easily. Oropharyngeal airways, nasal pharyngeal airways are some options you can have. iGel is not really helpful because it's mainly for surgeries. And the bag is called ventilation with self-inflating bags. Then like every time I keep doing this to the nurse, like this bag, I can't remember what bag it was. So it's called self-inflating bag, okay? Airway escalation plan is CPAP, BiPAP if the oxygen doesn't work anymore, so the normal mask doesn't work anymore. And the next step forward is the asking the anesthetist to be involved in their intubations. B is breathing, right? You ask the nurse to do respiratory rate and oxygen saturation, and you go from chest upwards to neck, and then go down for ABG. So going from this way upwards, then down. But first of all, you do chest expansion, listen to the chest, percuss it, and then go on to neck, check the trachea whether it's central or not, and then going up, sputum samples if needed, and then going down, ABG if you want to do ABG. If you don't think that's really relevant, then you can wait for bloods. When doing bloods, you ask for a BBG. Some options to ask for during this process is chest X-ray, ABG, sputum samples. Be aware that COPD patients, their oxygen saturation is 88 to 92%. So you could either use a normal non-rebreathe mask and then say like, we could give him 5 liters of oxygen and then titrate it so that it's between 88 to 92%. Or you could just use a ventilator mask of 28%. Nebulizer, the nurse might ask you if you want to do it with oxygen or air, so double check with the patient's oxygen saturations. So something to be aware of is that if the patient has difficulty swallowing or coughing like non-stop, then you might need to kneel by mouth because of the risk of aspiration pneumonia or surgeries. And there was once I was practicing ATE assessment with the teaching fellows. I can't remember what kind of problem the patient has, a chest infection or something like that. And he was coughing horrendously, but he keeps saying like he is thirsty and he wants me to prepare him some juice. I gave it to him, and the teaching fellow changed the x-ray from a normal, beautiful cap to a wonderful aspiration pneumonia. So be aware of that. If the patient has difficulty swallowing or coughing horrendously, you might need to kneel by mouth and give them IV fluids, okay? Nebulizer, you can ask for that. And going on to C. C-wise, you go from hands up to arm, and then to neck, chest, and then urine output downwards. Before starting it, you verbalize that, oh, we're going to go on to circulation. You ask the nurse to check the blood pressure and heart rate while you doing on the other side. So press the hand, cap refill time to say it, 1, 2, 3, 4, 5. If the refill time is less than 4, it's normal. If it's more than 4, check centrally, press it here, do it again, 1, 2, 3, 4, 5. How much is it? Check the pulse, and actually check for it, okay? The patient might have AF. And then going on to bloods. So I do bloods at last. So just be aware that there's something over here, okay? So there's the cannula site over here. So you go on, JVP, heart, listen to the heart for heart murmurs, and going down urine outputs, so fluid balance chart. And then if you want to check for any late edema, double check on that. And then go back to the bloods, okay? So bloods wise, you ask the nurse to do 2 white ball cannula, but sometimes the nurse doesn't know what do you mean by white ball. So you could just say like green or gray, like just 2 green cannula on both arms or 2 gray cannulas on both arms, and give fluids like 500 ml of 0.9 sodium chloride if the blood pressure is low. You could remind the nurse that repeat the blood pressure after the fluids is finished, and they'll do that for you so that you can have a new blood pressure to see whether it responds to the fluids that you give. You can ask for blood. ECG, usually you ask for it when the heart rate is fast or slow. So if the heart rate is more than 100, 120, I think, you ask for ECG already. And chest X-ray, medication, prescribe it. Going on to D. So D-wise, BM, the normal range of it is 4 to 7. And this is the part where you need to be aware of hypoglycemia and DKA. And there was once I was doing a DKA scenario. I didn't know about the BM. And when I asked the nurse to do a BM, she said it's 53 millimoles. And I said it's normal. So apparently, like when DKA patient, the BM is usually around like above 20 or above 30. So that's the part when you need to spot the alarm about doing a ketone again. So ketone is more than 3, and then you double check the ABG previously that you have done, whether it's acidosis or not. The pupil, like shine bright light into the eyes, temperature. APO, you don't really need to do it, like whether the patient is alert or not, because you'll be talking to the patient alongside. So if they suddenly lost conscious, then you'll probably catch it. E for relevant examination, so that includes PR as well. So if you feel like there's some bleedings from back passage, for example, upper GI bleed with melania, then you will say that you will do a PR exam. Say that you will expose the patient for any skin rashes or bleeding, and then other things you can order is stool sample, urine sample, like urine dipstick for UTI or pregnancy tests. Some things to remember during the process is that you can ask for guidelines. So that includes antibiotic guidelines, for example, aspiration pneumonia guidelines, and pneumonia guidelines, I'm not sure whether they will be able to provide you. AF guidelines for sure, upper GI bleed guidelines, major hemorrhage protocols, MI probably, all kinds of things. So you can ask for guidelines. Other than anaphylaxis, you still have to give like adrenaline ASAP. They would expect you to know the dosage of anaphylaxis. But other than that, I think most of the things, they would technically provide you with the guidelines. And you can also check the BNF at the back of it. There's the colorful page where there will be asthma, MI, adrenaline for anaphylaxis. The dosage is over there, so double check on that. Every patient needs VBG and ABG because in real life, blood probably takes around 3 hours for it to come back. VBG takes around 15 minutes, which is quite fast. So that's why you ask for it. Interpretations of the results, still remember to revise on it. And if the patient needs surgery nearby mouth, the bloods you will need to add on to group and safe, cross-match, potential coagulations if you feel like it's necessary. And make sure you talk to the patient alongside. Don't do it silently, okay? Just, for example, airway is clear, right? As a B. So, oh, sir, like, John, your oxygen saturation is a bit low, so we'll give you some oxygens, okay? Or here's some nebulizer medication for you, for your breathing. And they will thank you, like, oh, thank you, doctor. You'll be like, no worries. For blood, you probably say like, oh, your blood pressure is a bit low. We'll give you some fluids, or we'll take some blood from it, if that's alright. So talk to them alongside. Don't do it silently, okay? And I wrote like call for help earlier. This is the part I'm not very sure because some people say it differently. So what I mean by that is that so some people say it differently. So for example, if a patient has upper GI bleed, okay, he is vomiting lots and lots of blood, his blood pressure is 90/60. At that time, should you call for help or should you do a D or E to finish the ATE assessment and then call for help? And my take is that, to be honest, I'm not really sure on what's the model answer for that. But if you feel like this patient is going to pass away, then probably call for help, obviously. But then if, let's say the upper GI bleed, you give fluids 500 mils, 500 mils. So 2 bags already. It's still not working. Probably quickly do a D to check for the melania, so the stool, and then E feel the abdomen, E for exposing any active bleedings, and then call for help. So what I will do is I'll finish the A to E assessment as fast as possible, skipping certain parts so that I could have a quite a full A to E assessment for me to present it to the examiner. But different people might say it differently. So ask your teaching fellows or ask the people around you what their thoughts about that is, and verbalize it. So obviously you should say that airway is patent. We'll go on to breathing, we'll go on to circulation, we'll go on to D, we'll go on to E, so that the examiner knows that where are you now. And finally, the part that I wasn't really good at was the call for help, so SBAR system. So now this is the structure of how I call for help. So pick up the call, you say like, hello, my name is Chris or Chong, Yu Chong, F1 doctor, I'm in A&E ward. So if you're in A&E ward, you call A&E reg. If you're in medical ward, call med reg, okay? So you call the person above you, A&E reg, hello, can I speak to you now with a patient called John, 55 years old, who suspect to have sepsis secondary to chest infection. Can I ask for some advice or ask you to come and review him? So from the first 2 sentences, you can see that the person on the other side will know that, oh, okay, so who this guy is, where he's from, as well as who this patient is, what kind of problem he might have. You tell them this patient as well. So, oh, this is very severe, like this patient has chest infection causing sepsis already. And finally, the med reg will probably know that, okay, so you want advice or they need to remember the information and they might come and review the patient. So going on to the B, so background. So you go on to in more detail slightly. So this patient, 55-year-old John, chest pain, coughing up green sputums. He has a background of COPD, significant smoking histories, and we suspect to have this, and that. A for assessment. So A to E assessment. You tell them the actual figures of the observations. So airway was patent, respiratory rate was, 32, very high. Oxygen saturation was 88%. Oh no, he has COPD. So yeah, let's say that 84%. But now on oxygen of 5 liters, he's 88% now. ABG shows this, chest X-ray shows like consolidation of somewhere. And when I listen to the chest, there's like fine basal crackles. C, so like blood pressure was this. I gave fluids how much already. Heart rate was this. ECG shows this. Blood shows this. Like I've given antibiotics of this, these and these. And then at the end, you just ask them, is there anything else you want me to do for them? Or can you come and review this patient? Then again, you'll remind them that what kind of things you want. At this point in time, probably the examiner will start questioning about different things. So as you can see that time is a bit strict. We only have 18 minutes and we need to do brief history, A to E assessments, as well as calling for help and some questioning phase at the end. But don't worry, to be honest, don't worry that much, because 18 minutes is, you can call it short, but it's not that short. You can say it's long, it's not that long either. For me, I usually finish it in around 12 minutes, I think. So I still got time for examiner to interrogate me or ask all kinds of random questions. Going on to the potential scenarios, these are the things I think might come out in your exam. So that'll be COPD, asthma, anaphylaxis, neck of femur fractures, MI, like ACS, right? Heart failures, chest infections, sepsis, DKA, PE, UTI, upper GI bleeds, major hemorrhage protocols. So when it comes to activating a major hemorrhage protocol, is that you call the switchboard, you tell them, oh, can I can you connect me to the blood lab? I say, yeah. And then the blood lab, hello. Yeah, hi, my name is Chris. One of the doctors here. Doctors at A&E wards. I would like to activate a major hemorrhage protocol for a patient called John, NHS number of who suspect to have upper GI bleed. Then they'll be okay. Then before they end the call, make sure you ask them, are you gonna ask a porter to bring the blood up, or should I send someone down to get it for me, so that you know that blood is on its way. And some rare things, I think potentially it would be very cruel to have Addison's disease, because it's very vague, very vague, like abdominal pain, general tiredness. You could say like they have bronze skin, but then it's still quite vague. And what you will see is the hyperkalemia, and you need to deal with it. But I don't think so though, to be honest. Pneumothorax, like needle aspirations, chest drain. Appendicitis, yeah, would you say it's too easy? Needle by mouth, surgical input. Okay, and when it comes to the mindset wise, I mentioned just now the 18 minutes is a bit rushed, but then previously I talk even faster than how I talk now. And one of the teaching fellows mentioned that she felt a bit rushed and overwhelmed when I talk so much. At that time, I wanted to show off my knowledge and structures on A to E assessments. I just want to show them that, you see that I know the structures. I don't need to think. And which made me keep asking the nurse to do lots and lots of stuff. So, nurse, can you help me do a blood pressure? Nurse, can you help me do bloods? Nurse, please do VBG, ABG for me. I prescribe fluids. After that, do a fluids for me, and then double check the blood pressure afterwards. That was a bit too much for her. So slow down. When sitting at the side, looking at the other people's performance, I think the best one would be people who are quite slow, quite calm. Like, okay, we'll order some bloods for you. And nurse, can you take some bloods for him? And then after a while, like you're still doing some other things, right? And then, okay, nurse, can we ask for a ECG machines? So I give them one job at a time, so that the examiner as well as the nurse will feel less stressful. Another thing is that you can make notes before handing over. So I sometimes do that. To take a 30-second notes on to collect all the thoughts as well as the data from the observations, calling the reg. And that'll be quite helpful for when presenting your SBAR as well. So I recommend doing that before like rushing in, and after finishing E, you need to immediately pick up a phone and start calling your reg. You can slow down, chill a bit, 30 seconds, write down the things, and then call the examiner, okay? Finally, we'll go through my results. So my feedback, and this is the feedback that the one I felt. And it was a COPD patient, it was an exacerbation of COPD, and I was really rushed. I was giving lots and lots of jobs for the nurse. I was fixed-minded on prescribing doxycycline for this patient because I thought that she has bacterial infection. So if you have a look, didn't fully check the functional state, you don't need to do that. I don't think that's important. Disjointed, giving IV hydrocortisons, lost flow. I think the reasoning behind this feedback is that I could have prescribed prednisolone instead of IV fluid, IV hydrocortisons. But after asking so many people and teaching fellows as well, everyone prescribed the medication alongside when they're doing. So do that because it's safer. You prescribe nebulizer, prescribe it on the paper. If you ask for bloods, do the blood chart. If you prescribe prednisolone, do it in a medication chart. Okay, disregard whatever the examiner was saying about the loss of flow. Communication, I was talking to the patient alongside, which is extremely reassuring. It's good. Identifying the exacerbations, yeah, you can see that younger myself was really fixed-minded on antibiotics, which is not very good. Struggle to merge the findings of ABG. So what this means is that patient, a 60-ish female patient with a significant background of COPD and has increased shortness of breath, and it was an exacerbation of COPD, right? The ABG shows type 2 respiratory failure. I knew it, but I don't know what kind of management can have with that ABG results. So what it meant is that when giving ventilator mask or non-breathe mask, if it doesn't work, you go on to start thinking about NIV or CPAP. So, and that depends on your ABG. So if the patient has type 1 respiratory failure, so oxygen low only, then you give CPAP to flush the air in. If the patient has type 2 respiratory failure, which means that both CO2 and oxygen are deranged, then you give BiPAP to assist their breathing. That's the answer for that question, okay? Unable to mention or discuss NIV. That's what he meant. Prompt to ask for help. So the reason for that is that because I was so focused on prescribing doxycycline, I was flipping through BNF like a lightning, and then it lost a lot of time when I got to half of D. So I haven't even got to temperature. The nurse asked me whether I should call for help. So she stopped me. Well, not really. So she advised me to call the examiner, so the reg. So I wasn't able to finish my A3 assessment. So be aware of the time. And yeah, then you can see that the knowledge, things like that, a lot of things to improve. But on the second one, which is a upper GI bleed, so it was a like 60-ish male with a vomiting of blood, recent significant high intake of alcohol for the past week, ibuprofen used without PPI for his knee pain. Then that sounds like a upper GI bleed, isn't it? So I asked for alcohol history, examined only the anterior, and apparently she wants me to examine the back of the chest. But personally, I disagree with that because there's no time. There's no time to ask the patient to sit forward and listen to the back. But if you got time, or if you wish to do that, go for it. I got 2 out of 3 marks for examination. So 3 is the highest mark. So I got 1 mark deducted. I think that's reasonable, fine. Clear communication is okay. Reassess after the fluids. So that's what I meant. So the patient wasn't responding to the 500 mils of 0.9% sodium chloride. I gave 2 bags. He wasn't responding. So major hemorrhage protocol. I asked for the guidelines. It was really messy. Like there's so many things on that. So I just decided to call for help at that time. Reasonable differential diagnosis because upper GI bleed, there's not much cause behind it. So like peptic ulcer, mammary waist tear, liver problems like varices, gastric cancer. That's all. There's not much causes of upper GI bleed. For oxygens, she said it's not appropriate. I don't know what she meant. I don't care. And I did coagulation group and safe for potential endoscopy and surgery management for that. So overall, you can see that A to B assessment is simple in terms of the cause is quite clear. They won't challenge you on a random niche medical conditions. It will often be something that we've seen, something that is easy to manage. But the hard part is that instead of finding the cause of it, you need to do the appropriate management at the appropriate time. Okay, so B for nebulizer, C for antibiotics, Like I think that's the hard part, as well as the time. But that's everything I know about A2E assessments. And if there's any questions or concerns in regards to this, feel free to comment below or fill out the Google questionnaire. I'll have a look. But thank you for watching. In the next video, we'll talk about the communication skills, the communication stations. So thank you for watching, and I'll see you in the next video. Bye.